thank you so much. So, equitable prescribing of medications for opioid use disorder in Black populations. Of course, there's a lot that we can say about this topic. So, I hope this, my presentation can spark a fruitful discussion in the Q&A section. Unfortunately, I can't cover every single thing, but I hope that I do leave you with some type of information or an impression that can bring attention and awareness, and hopefully a change of narrative when it comes to prescribing for Black populations and historically, underserved populations. So disclosures, we're going to go through all of these. I know you kind of touched on some of it. I'm good to go.
Just
okay, perfect.
Just show it. Yeah.
No financial relationships here. And then, of course, we have educational CMEs and CNEs for professionals here. So our learning objectives, at the conclusion of this activity, we hope to analyze and summarize inequitable prescribing of Vivitrol, buprenorphine, and methadone, briefly discuss the history of addiction care, summarize harm reduction principles, which is something that I'm really passionate about, especially how we integrate that into clinical practice, and then identify and address stigmatizing language, discuss a little bit about implicit bias within the healthcare settings, and then we'll open up to Q&A. So today we'll discuss the history, as stated, prescribing practices, a little bit with insurance coverage, harm reduction, examining your own implicit bias, and then resources for your organization as well. So before we jump into the history, I actually want to share a different screen here really quick. So before we jump and start talking about the history of medication use, I have to kind of briefly give a little historical perspective on how we even got to the history when it comes to medications, and also just draw attention and call out what is taking place in our country when it surrounds substance use. So I put these images up. Hopefully people can relate or have seen these images or spark some concern internally as you look at these, because these are very stigmatizing images based on a belief of individuals with addiction or substance use disorders or, a problem to society. This idea of the war on drugs, quote unquote, it led to racial disparities, and especially disparities in policies that we see today, and even how we practice medicine and who has access to care and treatment when it comes to jail and those who are in prison. So I also want to look at the media portrayal with this image. The media use terms as, crack babies and crack cocaine kids, crack bills. You have the Time magazine, fighting cocaine in its grips. So it was a lot of stigma that came out even before we got to this point of treatment as it relates to our drug policies and how people overall approach this. So a few things that I do kind of want to lay this foundation with, starting back in 1875, like this isn't anything new in the 2000s, but going back to 1875, when San Francisco passed the first anti-drug law to ban opioid, that was specifically related to our Chinese population that came over then. And then fast forward, multiple policies, of course, in between that, but fast forward to 1986, when we have the Anti-Drug Abuse Act, in which there was a greater sentencing disparity for crack compared to powder cocaine. And we all know that your crack cocaine was located predominantly in urban neighborhoods, and your powder cocaine was located primarily in white urban neighborhoods. And the sentencing for 5 grams of crack was a minimum of 5 years compared to 500 grams of powder cocaine with 5 years. So thinking about big picture policies, U.S. This drug, quote unquote, war on drugs, and how this led to the significant disparities that we see here. And fast forward to today, our language, the narrative around substance use has significantly changed. Now we're saying substance use disorder. We're using terms as neonatal abstinence syndrome. We are declaring this a state of emergency when this should have been declared years ago. So the opioid epidemic was framed as a white problem, especially as it started to move into white suburban neighborhoods, when it should have been framed as a problem back in the 70s and 80s. The current political narratives didn't even pay attention to the rising death rates among Black individuals. We still had restrictive treatment and imprisonment in Black populations versus connecting to care and treatment. And then access to office-based treatments was primarily located in your suburban white areas. So I just wanted to draw attention to just this change from a high-level political system now since it moved to white neighborhoods compared to before when we had mostly our Black and brown populations being disproportionately impacted. So let's talk a little bit about the history of treatment and how we got to where we are with this. So in 1972, that's when methadone was officially approved for treatment of opioid dependence. But methadone itself was around during World War II. So actually over in Germany, that's where it was initially designed to help treat pain when there was a shortage of morphine. In 1947, the U.S. introduced methadone as an analgesic. And then in the 1960s is when they really started to focus on or look at methadone as a treatment for opioid dependence. And in 1972 is when we had the initial approval to use methadone for opioid dependence. So a lot of us are comfortable with methadone. We've heard about methadone. It was considered the gold standard. Problems with methadone is that it's highly restrictive. There's a lot of regulations, of course, requiring people to go every day. And because of the stigma around methadone and the strict restrictions around it, we started to see methadone clinics pop up in primarily marginalized communities and urban neighborhoods because there was a push to not have methadone clinics open up in white areas. And then in 1969, I just want to point out that Washington, D.C. was the first to open its methadone maintenance treatment program in 1969. Fast forward in 2002, we had approval of buprenorphine, and it's unfortunate because we had 36 years of research before buprenorphine was actually approved to treat opioid use disorder. When buprenorphine was actually first released, you saw it in private offices in suburban areas. So access to buprenorphine looked a lot different compared to access to methadone. It was less stigmatized. It was, a primary office type setting that people were able to access buprenorphine. It was initially marketed to those for private insurance, those who had the ability to self-pay, and again, introduced to private offices. So even with that, we created this disparity of who can access methadone compared to who can access buprenorphine and where those treatment centers were located. In 2010, Vivitrol was approved to treat opioid use disorder. Even Vivitrol itself, there's some stigma among the medical community. What we do know is methadone and buprenorphine are your agonist treatments, and Vivitrol is your antagonist treatment. So a lot of people were pushing Vivitrol as an antagonist of treatment because even physicians felt that, methadone and buprenorphine was just recirculating a different form of an opioid and not truly treating someone's addiction. We'll talk a little bit about that, but that was the stigma that was among the medical community. And when Vivitrol came out, you had a lot of people pushing for Vivitrol because it's not quote unquote substituting one drug for another. It's an antagonist. One thing with Vivitrol, I would like to point out, although it is a great medication, there are some concerns that come with Vivitrol. Individuals who have started on it, they do great. But if there's any period of time in which they stop treatment and then they return to using substances, heroin or fentanyl, it actually can increase someone's risk of an overdose. So one thing that I'll always counsel on whenever I talk about these medications is that risk is there with Vivitrol, and I don't see too many physicians or prescribers really talking about that risk, especially as it relates to certain communities and populations that we're dealing with. So for example, a lot of times with my patients, we'll talk about all three, but a lot of times with individuals in the Black community, they go back to using or back to their environment, the support for Black individuals with substance use disorder, it does not look the same for support for your white community. So I do want to point that out as well, because that's really important going forward. As you decide or discuss treatment options with individuals, you always want to make sure you address this as well. So treatment for addiction care, back then addiction was viewed as a criminal behavior. You didn't really get to, the later 90s, early 2000s, where this switch in language, even in the medical community, to start really viewing it as a substance use disorder. Even back then, you only had psychiatrists during that time treating for it. It was unheard of or uncommon for internal medicine or a family medicine physician to be able to treat this. And even in our medical schools, we were not abreast with the knowledge to be able to treat this. I think a lot of us, we were taught on how to take a social history and to gather the information. But as far as treatment plans and discussing treatment options with patients, it was a referral to a psychiatrist. So even within when someone enter or access our healthcare system and we talk about medication options, you were referred on. You were not a lot of times offered treatment right up front if you were seeing a primary care physician for your treatment. So racial disparities in access. So Black people face multiple barriers receiving just equitable treatment to SUDs. So Black people less likely than white people to receive treatment for it. Black people are less likely to even start on treatment at that first visit. Buprenorphine was developed in part to overcome the stigma, but what we still see is that Black people are still underprescribed buprenorphine compared to white people. You still have a big push for methadone in your Black communities compared to discussing all available options like buprenorphine, and I'll even put in Vivitrol as well. I think a few other things I want to point out with the racial disparities is also multifactorial. We have to think about stigma, of course, stigma with treatment, stigma with being Black, and even racism, and even also your Black and brown communities. Black and brown communities in which we see substance use disorders predominant. You have to also consider incarceration rates, that there's a difference in various jails and prisons in offering treatment. Enrollment in Medicaid, we'll talk a little bit about the insurance, who has private insurance compared to your public sector insurance. Increase in fentanyl use in urban areas as well. Among patients who experience non-fatal overdoses, Black patients are half as likely to obtain follow-up appointments after a non-fatal overdose compared to somebody who was white, and even being able to start or being discharged on medications from the emergency room. Racial segregation prevents differences in access to methadone as well as buprenorphine, as I previously addressed. So increased uptake in buprenorphine as an OUD treatment, it remains primarily accessible to those in the white community. Here in St. Louis, there's more of a push to really offer access to buprenorphine products compared to methadone. So in the last few years here in St. Louis, there's been a major shift in movement to really talk about the benefits of buprenorphine and get our prescribers here locally to feel comfortable prescribing buprenorphine on a primary care level. So let's discuss briefly about the differences in rural versus urban areas. So in 2018, 57% of rural U.S. counties had no clinician approved to prescribe buprenorphine. Even after the pandemic, you still see significant disparities in prescribers as well as access to treatment in rural versus urban areas. So some of those barriers in rural setting, of course, a lack of prescribers, inadequate access or coordination with behavioral health services. And I also want to make sure that, it's not a requirement to have access to behavioral health services. It does help when it comes to treatment. But for some people, I've seen providers say that if there's no access to behavioral health services, then I can't start you on treatment, which is, inappropriate. Lack of training in the treating physician. A lot of times it was psychiatrists. So how can we get our primary care providers, even our nurse practitioners or physician assistants, to feel comfortable now making this a routine part of their wellness visits for individuals they see in a primary care setting. Stigma towards patients with addiction care. I do remember that here in St. Louis at one of my clinics, when I was advocating on integrating addiction care into primary care, I had quite a few of my colleagues afraid or concerned that these people are going to come in and start stealing from our waiting areas. And I mean, it was just surrounded and filled with stigma and misunderstanding when it comes to someone with a substance use disorder. Lack of adequate funding or reimbursement, specifically from Medicaid and Medicare. Here in Missouri, we are completely behind the line when it comes to expanding Medicaid coverage for individuals. And so without appropriate funding, especially for public health departments or for our FQHCs, we tend to take the brunt of the funding for that, where you have funding for in certain private sectors or academia when it comes to this, but getting access to funding for those who are practicing medicine or for those public health departments who have integrated clinical practices as well. So these are just some of the disparities that we see are differences in rural versus urban areas. And just a little bit with access to coverage. So Black people are 1.5 times less likely to have access to health insurance. Of course, we all know that this decreased access to healthcare, number one. It tends to create an environment where we overutilize the emergency departments. And again, individuals who are seen in emergency departments are less likely to be started on treatment or even connected to resources after follow-up, less likely to engage in prevention activities as well as treatment, less likely to seek care because of the cost, distrust, or discrimination. And then we also see higher rates of other chronic diseases such as diabetes, hypertension, HIV, AIDS, other chronic illnesses that often go left untreated when individuals don't access healthcare. So I absolutely love FQHCs. For those who don't know, Fairly Qualified Health Centers or community health centers, especially those FQHCs that integrate addiction care into their primary care practice. I always say that a primary care practicing physician or provider, we can provide that holistic care. So although we get individuals to come in, maybe focusing on addiction care, you can get their vital signs. You can also start treatment for hypertension, have those discussions about other chronic diseases, and care for the individual in a holistic manner, and not only focus on one aspect of that individual's life. And we can talk about in Q&A about my experiences with that, but I always offer the opportunity to address the addiction care part, but also let's talk about everything else that can promote overall health and well-being, not just only focus on this one component of your health. So harm reduction, let's pivot a little bit. I love talking about harm reduction. I do think that's the way that we need to go. Truly embrace harm reduction and not keep it as a treatment all or none. One thing we do know is that drugs are going to be a part of our society. They've been a part of our society. It's a reality that we all need to accept. And we are going to have individuals who are going to use drugs. I think one thing with that, knowing that we need to create an environment in which everyone still feel welcomed and accepted, no matter what stage of their recovery that they're in. And when I say recovery is not abstinence, so also recognizing that as well. So harm reduction itself is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. So specifically, we want to keep people alive, and we want to also recognize the reality that substances are a part of our communities. So harm reduction in those principles, it respects the rights of individuals who use drugs. It actually gives them a voice, and it centers individuals who use drugs. It's a spectrum of strategies. It's not an all or none. It does not push for cessation of use. As a goal, it actually works with the individual and identify what those recovery goals could look for them. And if someone is actively using, it creates an avenue or a pathway for individuals to feel comfortable talking about how to use safer, so that way we can save a life. And it's also it's a spectrum. So some examples of harm reduction, and here I want to ask people as we're talking to put in other examples that you are aware of. There's multiple examples of harm reduction, but of course, getting naloxone into our communities, carrying it on individuals in the community, and not only waiting for people to interact with a EMS system or a firefighter or a police, but truly educating and teaching the community and residents on how to respond to an overdose in our communities. Syringe exchange programs, of course, medications, fentanyl test strips, consumption sites as well, incorporating safer use methods into treatment plans. So one thing I did, when I would see someone, as far as my assessment and plan, yes, we will talk about all of the medical treatments, but also let's incorporate safer use, coaching or discussing with someone that is safer to snort versus using IV drugs to decrease your chances of developing an infection of some sort, whether it's a skin infection or endocarditis. Educating people on how to clean their injection site. For a lot of prescribers, those conversations make people feel uncomfortable, but those are the conversations that we need to have if we want to, number one, save lives, but also embrace this concept of harm reduction. We have the knowledge. Let's share that with individuals. And Brooke, I don't know, there are other examples being dropped in the chat. I can't see it right now.
Yes. Carla said, don't use alone.
Yes, don't use alone. That is true. That 1-800 never use alone number. That has saved a lot of lives. And I always put that on my after visit paperwork as well, so individuals will know that they have a number to call. And I explain, um, you know, when calling, what that number would do. Other things too, it makes people uncomfortable, but having a friend, if you are going to use a loan, call someone or let somebody know so that way that person can check in on you. It's a different type of concept, but we're truly, discussing trying to save someone's life here. Go ahead, Brooke.
I also, where did it go? Mail order pharmacies.
Yeah, mail order pharmacies. Yes.
Test the dose first. Oh, and wound care resources.
Yes, yes, those are really good. Testing a dose, that is one thing that's really, really important, especially for individuals who are, recently justice involved individuals or those who are returning the use. That should be incorporated as well. Test the drug, test the dose, go slow before going back and returning to the amount that you were using. But these are tips and actually counseling that we should be providing individuals who use drugs. And what was the last one, Brooke, that you said?
Wound care.
Wound care, yes, providing wound care. So here at the St. Louis County Health Department, we actually released a spectrum of harm reduction. So we have a safer consumption kit that would include your cookers and your filters, but we also have a wound care kit as well with instructions on how to properly clean a wound. So we have, soap, a washcloth, your alcohol pads in there. We have Neosporin, Band-Aids, a little informational handout as well on what to watch out for if you notice your wound is becoming signs of infection. We work closely with one of there's a harm reduction organization here that works closely with other grassroots organizations to get this information out as well. So now I agree with you discussing that wound care is really, really important and educating individuals on how to care for the wound before it becomes infected.
There's a couple of the really awesome responses I want to share with
Oh,
you.
go ahead.
Amanda mentioned encouraging use in the Fowler's position to avoid asphyxiation.
Yes, yes, yes. That's a really good one. We don't talk much about that. Thank you so much for putting that in there, Amanda. That's a really, really good one. It's really important.
And Eleanor noted that they have mental health co-responder teams that work with police officers to help keep folks using drugs out of jail and sending them to a mental health facility if necessary.
Yeah, co-responder programs. We have some here in St. Louis as well. We need to work through some of those, but I agree with those programs to divert someone from a jail to a hospital or behavioral health urgent care setting. It would be really nice if we can create some type of innovative idea where this diversion is not to a hospital, but maybe to a primary care physician, because oftentimes a primary care doc have that relationship. And when you see a different doctor, especially when you are in acute crisis, you may not feel as comfortable, discussing or repeating your entire history. If we can create something where we have different clinical times in which, maybe the primary care clinics can eventually maybe stay open to 12, 1 or 2 o'clock in the morning. That would be something that I would love to champion across the nation if we could. But if we can divert to primary care doctors and get individuals established with a primary care doctor, that will be one thing that could definitely be innovative. So that way, when somebody show up, you don't have to repeat your whole story. And you don't have to, prove the case of why you need a medication. Is, you're seeing the person who already been taking care of you, who's already aware of your medical history, and that person can just jump in and start with their intervention or start with the counseling or go in and talk to the individual. So no, those are really, really great ideas and really great thoughts and examples. Let's jump to discussing barriers to implementing harm reduction strategies. Of course, stigma in the community and our healthcare settings. So just even when we think about, how access to naloxone rolled out, there was significant stigma in the community that, oh, now you're enabling someone to be able to use drugs because you're going to save their lives. Believe it or not, I actually heard that in one of the community meetings that I attended when we first started expanding naloxone access in St. Louis. And now fast forward, carrying naloxone, using naloxone is not as stigmatized as it was before. But if we think about other things, syringe exchange programs, here in St. Louis is still highly stigmatized. We cannot get any bill or anything passed with it. Even when the health department, when I wanted to start handing out harm reduction kits for wound care, or even for safe smoking, highly stigmatized, just because, this idea you're enabling someone, which is, we need to start changing up that narrative around that and get away from this term of enabling and moving away from something being punitive. Lack of training or guidance at implementation. So again, when it comes to medical training, whether it's nurses training or physician assistant, nurse practitioner, a lot of times we are not taught the root or the reality when it comes to substance use disorders. Is often get the history. Now in some medical education programs, they're discussing a little bit about treatment, but really leaning into harm reduction practices and ideas to save somebody's life, and creating that space for if somebody returns to using, they can come back and see you. Oftentimes when we counsel or talk to somebody, is abstinence or nothing, or is treatment or nothing. We do not create the space sometimes for somebody to have a recurrence of use and then feel comfortable to come back and see you. So creating those opportunities of, if you do go back to using, this is how I want you to be safe, and then providing the instruction on how someone can safely use so that you can see them at that next visit. A lot of times it's punitive. Oh, if I go back to using, I can't go back and see this particular doctor. And they came up with the methadone treatment clinics and how they roll those out with being restricted, that if somebody returned to using, the dose was cut in half. And what we know now, why are we cutting someone's dose in half if we know they have a substance use disorder? Because it's going to increase their likelihood of using more. Cost, space, time, those are other considerations as well. Again, drop in the chat other barriers for implementing harm reduction strategies. The other thing that I would call out, political party affiliation. We do know there's a strong division between Democrats and Republicans when it comes to supporting harm reduction versus not supporting harm reduction principles. If you live in a highly politicized environment, that can become a barrier to truly implementing harm reduction. Sometimes spiritual or religious beliefs about addiction care. There are still some religious groups that believe that, this is all based in the spiritual ground. If you just turn to your spiritual entity that you believe in, that you will be okay. So even then, incorporating medicine into the spiritual space is different, but sometimes people have really, really strong spiritual beliefs that can hinder them from either accessing care or even believing or knowing that harm reduction strategies can work. Brooke, was there any other ideas that came in that's in the chat?
Yes, syringe service programs, cultural beliefs.
Yes, yes. Cultural beliefs are really huge, and I was kind of hitting on that with the spiritual, but with cultural beliefs, just in the Black community, I mean, there's still a lot of people who believe that, if you use drugs, that means you're bad. You're going to steal my purse. You're going to rob me. You're going to do all of these bad things to me. So I better stay away from you. Family members need to stay away from you. Or if you have someone who's coming to a family reunion with a history of substance use, there's a lot of stigma that's still there, cultural beliefs, around substance use that do not create an environment for somebody to feel comfortable with saying, I once was using, or I'm currently using, I want treatment. And there's still stigma related to treatment. Oftentimes I found that individuals that I would start on buprenorphine, they would want to go back to methadone just because methadone works. I don't know about this buprenorphine. And we're talking about, just in 2022, 2023, people still thinking that methadone is a better treatment than buprenorphine, or still thinking that there's some type of stigma behind using buprenorphine and methadone. I only want Vivitrol because it's an antagonist, or it's not it doesn't work like the other one. So even then, we see those type of beliefs show up in the treatment space, but also in the community. Go ahead, Brooke.
Kathleen noted specifically a pregnant woman's with OUD fear of incarceration.
Yeah. Fear of incarceration or fear of having your baby taken from you. Those are real fears. There's data to support that back in, the 90s and the early 2000s, that unfortunately you had DFS coming in, and really, instead of providing support for the pregnant woman, the focus was on, putting the baby in a safe environment. And what it was essentially doing, it was taking the baby away from the mom. Because of that, it wasn't thinking about, let's connect mom to treatment resources. Let's keep mom and baby together. Because of that, yeah, that's a really big one. And we actually don't talk too much about opioid use disorder and pregnancy and the impact on families and babies. We need to get to a point where we are discussing pregnant women and supporting pregnant women early on, so that way they'll feel comfortable entering care in the first trimester versus waiting to the third trimester. So we do need to have those discussions early on. That's a good point. Confronting stigma and implicit bias. So what is stigma? Bottom line, stigma is when you think someone is to blame. There's no facts or basis with this. This is, there's two factors that can influence the stigma. When people think about there's a lack of controllability or a lack of cause, but stigma can show up in many different spaces. And sometimes stigma or implicit bias can be, it can be unconscious. So stigma decreases when it's perceived to not be someone's fault. So for example, even when we use terms like substance abuse or substance abuse, I tell my medical students and residents who train with me that we can somebody an addict or a substance abuser or substance abuse. I say substance use disorder compared to somebody to say, oh, this person's a drug addict. So just even with those terms and terminology, it creates a different impression for someone. If we say substance use disorder, you're thinking more so about let's connecting someone to treatment resources because it's a medical condition versus the stigma that's related to the term drug addict. And just to put that out there, I absolutely do not like the term drug addict. I always tell people like, no, you are not a drug addict, because I feel like that's also loaded with so much stigma and bias. And we've made people believe that, oh, this term addict means that you're a bad person. And no, you're a person who uses drugs, but even just with using that, there's an issue. When we say substance abuser, it makes it seem like that, oh, somebody's willfully using drugs, or this is something that's willful. We can blame the individual then versus blaming the systemic racism and systems that we put in place that can lead somebody to using drugs and the traumatic experiences that people have experienced in their lives. And so just simply blaming the individual and saying that, oh, this is your fault, is something, we definitely need to move away from that. So how do we confront stigma, and what is it? In this space. So of course, the different types of stigma, blame yourself or feelings of hopelessness, stigma from the recovery community. Within that community, there's a stigma for somebody who used medications versus somebody who can go cold turkey and go to abstinence route. So even within the recovery community, there's still some stigma that exists, or for some people that, oh, I was able to do it without medications. That mean that, I'm better at this, or I'm able to I'm strong-willed. I can get through this on my own without the use of medications. Versus somebody who used medications, oh, that means you still need help. It makes it seem like that somebody have a disability because they decide to use a medication, but we don't do that differentiation when it comes to treatment for diabetes or treatment for hypertension or treatment for other conditions like asthma or COPD. We don't talk about it in that same sense. Stigma from clinicians, a belief that treatment is ineffective. We still have providers who feel that treatment is not the best option, that behavioral support is the only option for some individuals. Our treatment means that you can start short term, but this is not anything that we're going to continue long term. So even internally, when somebody do access a healthcare system, you still have stigma and bias in the clinician that could be treating. And that can perpetrate an individual being able to continue to seek treatment options. Stigma from outside, again, that choice is a moral failing versus this is a chronic disease. So you can also see that as well when we discuss in a systems level individuals who are diagnosed with a substance use disorder. So a little bit about implicit bias. So implicit bias is the assumption that the subconscious associates towards the characteristics or individuals. And sometimes this can be something that's known or unknown. It can be positive or negative as well. I always encourage individuals to take an implicit association test to see where you are on that spectrum and start to address those implicit biases. Oftentimes they do show up in clinical practice. They show up in how we discuss and talk about addiction care with our colleagues as well. This is something as providers that we need to be aware of, and we need to be intentional, but identifying those biases and working on those biases so that way that we can be a contributor to positive outcomes and not inadvertently hurt someone because of our own biases that we may carry. So a little bit about racial implicit bias in healthcare settings. So there has been extensive research when it comes to implicit bias and how that show up in healthcare settings. So what we know that a physician's behavior, a provider's behavior, whether it's verbal or nonverbal, can interact clinical decision making as well as the patient interaction. There's differential interpretation of clinical presentations among individuals. The one thing that I hate to see in someone's medical chart is that somebody is drug seeking. If you see a history or diagnosis of sickle cell disorder, then, oh, somebody is drug seeking. No, this individual is likely experiencing significant pain as it relates to the sickle cell. But the next treating provider who see drug seeking, that type of bias will tend to be continued in the notes going forward for the individual who interacts with our treatment center, treatment clinicians. There's differential in treatment recommendations. Again, we tend to see that methadone is still a preferred choice in Black communities compared to buprenorphine being an option. You also see in the private sector. So some private sectors cannot offer methadone, of course, but when it comes to buprenorphine and Vivitrol, you still see individuals being offered Vivitrol over buprenorphine, in which we know buprenorphine is an excellent treatment option. Providers tend to speak faster, speak more, and spend less time with patients of color compared to white patients. So we do see that as well. Patient bias, the historical trauma or the negative expectations when they interact with a physician. So even with that, and that has to do with the historical trauma of interacting with our healthcare system. So when that patient also show up, and I don't want to invalidate the patient experience, but when that patient do show up based off that previous interaction, there may be some bias that may show up into that. I've experienced that myself with being a Black physician and seeing patients that they come in with this patient bias because of their previous interactions with other physicians. And I have to kind of work to overcome that bias so people can see, who I am as a physician. And we can kind of, restart that relationship. There's a high level of bias that leads to less friendly interactions and lower patient satisfaction. Again, that goes back to physicians not listening to the individual in front of them, or physicians already having a preset treatment plan before listening to the patient to determine the best treatment plan with that patient and not even centering the voice of the patient. I still believe that, yes, as a physician, we can present our assessment and plans, but we also need to engage and discuss our assessments and plans with that individual. For example, when it comes to diabetes treatment, everybody can't afford insulin. So we can prescribe insulin, but we didn't even discuss with the individual. Are they unhoused? Do they have access to a refrigerator? Do they have access to money to be able to cover the treatment? Those same concepts need to be integrated into our assessments and plans to identify what resources do you have, or maybe somebody had a negative experience with buprenorphine because somebody did not coach them on how to properly start the medication. So therefore, there's some hesitation in starting buprenorphine. So you can learn a lot when we center the patient voice, but also include them in our assessment and plans when we discuss treatment and behavior care options and harm reduction options. This, of course, can lead to avoidance of healthcare altogether. It can impair the communication with the provider. It can also create challenges with medications and treatments. And ultimately, individuals can overdose and die, unfortunately. So implicit bias and addiction. So addiction stigma may also intersect with other forms of bias, of course, racism, sexism as well. So an individual who identify as being a Black person with substance use who also is in the LGBTQ community, we have 3 layers of bias and stigma that can be present in their interaction with someone if we don't start to address this. Individuals with SUDs may be treated less favorably compared to those who have those in other communities or in other neighborhoods. Minorities are significantly more likely to be arrested and receive harsher sentences for drug-related offenses. And that's completely true. We do see an over-incarceration of our Black men all throughout our state prisons as well as our local jails as well. Men are more likely to be sentenced and receive harsher sentences, again, specifically Black men in relationship, and I say our Black and our Latinx and Hispanic men. In relationship to people who inject drugs, data suggests a preference for punishment in an implicit assessment, but for help for those in an explicit assessment. I have seen that people may treat individuals who use IV drugs compared to those who snort or who take it orally different. Depending on the provider that you see. which is something, of course, that shouldn't happen. So let me provide you a little bit of tools to address implicit bias. So of course, you want to start with doing an implicit bias test to identify where those biases exist. Raising awareness of your own bias. If we don't recognize it and create awareness for yourself, it's difficult to try to work on those biases. Understanding the consequences of those biases. Again, it can deter someone from from seeing you in care. It can deter them from starting treatment or discussing other life-saving measures like safer use. It can also discourage an individual from wanting to talk about how to use naloxone to reverse an overdose. Recognize when these biases responses may occur, and for yourself, maybe challenging yourself that if you see that if you're in with a patient and you see that your biases are coming up, taking a moment to be able to reset as a provider. I don't think there's anything wrong with you needing to reset. I think oftentimes we feel like when we show up in these clinical spaces that we have to be the expert in the room, but taking the time to learn from the patient, but also just resetting mentally before continuing that visit can sometimes do you some good. Replacing biased responses with responses reflecting non-prejudiced goals. So one thing it could be when it comes to relating urine drug screen results, not saying that, oh, I review your drug screen is dirty for this or clean for this, but saying that you had a positive or a negative test, or the way that we relate information with drug screens. Another thing you can do is pull up the drug screen with the individual, go through, let them see what you see, and have a conversation around what does this particular test mean? What does this mean? And a lot of times getting a urine drug screen is only a snapshot. It does not tell the entire story, but the way that we relay test results to an individual can have a huge impact on if that individual will return to care and see you. Stereotype replacement, counters stereotypic imaging. Again, what I showed before, in our exams, in our offices, we need to think about what kind of images do individuals see when they walk into your office. Are they seeing pictures of Black and brown bodies, accessing treatment? Are we seeing images of pregnant women with substance use disorders? Are we seeing it, or are we seeing predominantly white pictures in our office spaces? Perspective taking, increased opportunities for context. So all different type of ways here that we can address these biases, but it does take work on our part to recognize and identify these biases, but also be intentional about how we address these and how they may show up in our clinical spaces. So how do we change the narrative? One of the most simplest things that we can do is first start with our language. Respect the worth and dignity of all persons, especially those who use drugs. Focus on the medical nature of the substance use. Don't think about focus on it as a disease. So I'm trying to say, focus on that part, that this is another chronic disease or disease that we're treating in the same fashion that we are addressing hypertension, diabetes, COPD, and other chronic diseases. Promote the recovery process. And recovery is dependent on the individual in front of you. Recovery does not automatically mean abstinence. Recovery does not automatically mean that you're in treatment. Recovery could mean something as simple from somebody was using drugs IV, and now the preferred route is snorting. So identifying what does recovery look like for that individual, and promoting and celebrating every aspect of recovery for that individual. And changing the idea of recovery, because a lot of people do think recovery means treatment or recovery means abstinence. Avoiding negative stereotypic biases, again, through slang terms. Again, the way that we relate urine drug screen results, or the way that we talk about substances, or what's going on in our community. I had a provider one time still, use the term crackhead when he was talking to another provider, and they were trying to, have a friendly conversation, but I took offense to that because I know the term crackhead and where that originated from, that's not anything that we should joke about. It's not anything that we should make fun of by calling someone, oh, you're a crackhead. So thinking about our own terms and slang that we may use either with our own colleagues or everyday language when we're talking to our family members. We need to use those moments to educate community members, educate family members, but also educate our colleagues as well. And catch yourself if you notice that you're using those particular terms. So I want to leave you with a few resources for your organization. The African American Behavioral Health Center of Excellence, great resources that's available specifically for serving Black populations. The Opioid Response Network, of course, another great resource. You can, submit ideas or submit thoughts to them. There's a team that can actually review either project ideas or review presentations for you as well. And then PCSS is something that I use a lot. A lot of people use that. Mentorship opportunities, learning resources, of course. I do like PCSS. I do feel like that is more up to date compared to some of your other resources that people may follow, especially when it comes to implementing MOUD in your practice, going beyond treatment, but also looking at cognitive behavior, looking at other treatments for cocaine and methamphetamine. So I do think PCSS is something that should be bookmarked on your laptops because it's a great resource for a lot of individuals.